everyone. We will just be getting started in just a minute or so. We're waiting for everyone to come in. My name is Helen Adioson. So we're just getting everyone in, and we'll get started with our panelists today, Madhuri Reddy and Colin Vick. So we'll give you a couple minutes to get into your comfy seat, get a cup of coffee, and we'll start our roundtable in just about a minute. All right, so we're going to go ahead and get started. Welcome, everyone. You made it through the week. You made it through the week here in Boston. It is very gray and very cold and rainy. It'll probably be that way until Tuesday, but I'm very, very glad to have my favorite co-founder on with me, Dr. Maduri Reddy. and Colin Vick, partner with Foley Hoag. So you are in the right place if you're looking for CareAcademy's COVID-19 Roundtable. It's our weekly webinar series where we talk with experts throughout the home care industry and answer your questions and get your feedback as well as your advice for other home care agencies and home health agencies within the industry as well. So with that said, would love to just roll in as you guys are getting seated, you're getting your favorite cup of coffee, you made it through the week, we're almost halfway there. If you haven't used Zoom webinars, so last week we switched over to Zoom webinars, a platform. If you haven't at this point, because I feel like it's everywhere right now, just in terms of working from home, the control panel is at the very bottom, and there you can chat up, raise your hand, or ask clarifying questions. We'll be going fast and furious through as many of your questions as we can get in for Dr. Reddy as well as for Colin. But if you have any clarifying questions or comments, go ahead and put them in the Q&A. So you click Q&A to ask your questions, and if we're going to ask your question live, we'll take you off mute, just so we can get through as many questions as possible and streamline it. We won't do that too much, but if you have any clarifying comments or questions, we've got a couple folks who are regulars at this point. We're happy to ask your question live. So it'll look like these two images that you see right there. So thank you so much again for joining us. And on to the next slide. So if you're not familiar with CareAcademy, we are the #1 provider of online training. We have 160 hours of training, including TPA SNO's dementia classes. We're designed for mobile. We are mobile first for your direct care workers. We have an online dashboard meant specifically for you and your staff to see how your caregivers are doing as they are taking their classes, and also make sure that they are ready from day one. We also offer a portable record. That means that a direct care worker can take their training from one place to another so they can get started even faster. We offer customer support because we believe in great technology as well as great support by humans for you all, and then an API integrations as well so that your technology can be seamless. So we offer that all at CareAcademy. If you're interested, by all means, reach out to us. So remember to submit your questions and responses below. We actually already have questions that we have received from you all, so we'll be asking those first. If you have any clarifying questions, I'll be taking a look at those as well. So without further ado, I have Dr. Maduri Reddy, our Chief Medical Officer and my co-founder of CareAcademy. Dr. Reddy is the Chief Medical Officer and co-founder, and is a specialist in internal medicine and geriatric medicine, and holds appointments at Harvard Medical School and Hebrew SeniorLife. For years, she's seen firsthand the struggles that families and caregivers go through while caring for older adults, Dr. Reddy has published several research papers in prestigious medical journals, book chapters, and also a book for families and caregivers. And Colin Vick is a partner with Foley Hoag, where he serves as the co-chair of its data privacy and security, and more recently, the healthcare practice groups and the co-chairs of the COVID-19 task force. His practice is focused on healthcare and compliance issues and often involves the intersection of those two subjects in investigations, administrative proceedings, or litigation. I'll read the next sentence, but you guys get it. Colin is amazing. His work has had a particular emphasis on compliance issues related to life sciences. So this is a great combination. I couldn't think of a more powerful duo to answer a lot of the questions that we have on deck today. So without further ado, I'll go ahead and start getting into our COVID-19 health update. Dr. Reddy, do you have some pointers about what's changed and what's happening this week that would be great for folks who are on the line?
Yeah, so what I thought I would do is just start with highlighting just the important facts and, like you said, giving you a few updates. So, I need to start with all humility because things are changing all the time. Infection control policies are continuing to evolve, and there are so many unknowns in this whole situation for everybody. So home management is appropriate for many patients with non-severe COVID-19 infection, and the focus when these patients are at home should be on the prevention of transmission and monitoring for deterioration of symptoms in the client. So the home care worker should primarily know when and how to apply proper PPE to himself or herself and for the patient, and also when and who to call when symptoms get worse. And regarding the symptoms, the most common presentation is fever. 99% of patients who get COVID-19 present with fever, followed by fatigue and a dry cough. But there are a number of other less common symptoms that can occur. So people who have any kind of respiratory symptoms like cough or difficulty breathing as well as fever should be encouraged to stay home for the duration of their illness and call their healthcare provider for further guidance. And individuals who are at highest risk for COVID-19 are those who have traveled to the high-risk countries in the past 14 days or have had close contact with a confirmed or suspected case of COVID-19. And close contact is defined by being within 6 feet of a person with confirmed or suspected COVID-19 or being any distance away from blood or bodily fluids or droplets of a person with suspected or confirmed COVID-19. A lot of the questions that we have had have been regarding the use of PPE, and the limited availability of PPE has really complicated care of patients with known or suspected COVID-19 worldwide. CDC offers guidance of optimizing the use of PPE, which includes prioritizing the use of certain PPE for the highest risk situations, and also a cautious reuse or extended use of PPE. And I'll give you the links for several of these things that I'm talking about at the end of the webinar. Regarding route of transmission of the virus, it's mainly thought to be respiratory droplets, similar to the spread of influenza. The droplets typically do not travel more than 6 feet or linger in the air. Period of infectivity, it's uncertain, but the possible transmission of this virus, called SARS-CoV-2, has been shown in asymptomatic people, which is probably one of the main reasons it's traveling so quickly, because you may not know when you're able to transmit the disease. Regarding immunity, you are likely to be immune if you've had COVID-19, but they're still working on the serology, and this is unclear at this point. Environmental disinfection is very important, and specific guidelines for the home are on the CDC site. Again, I'll share this with you at the end. And finally, the CDC has provided guidelines for work restrictions for healthcare workers who have had a potential exposure to COVID-19. So I think that's my summary, and I'll be happy to answer questions throughout as well.
Awesome. Thank you so much, Maduri. It's really helpful. And so I'll just start posing questions. And my goal for these, by the way, everyone on the line, will be to get as many questions in front of our experts as possible. Of course, and I'll do this also with the same sort of temperance that Dr. Reddy just mentioned, things are changing on an almost daily basis. I think we've all, at this point, we're almost a month in and we all appreciate that. So bear with us and we'll try to get you the best information possible at that time. So first question, Colin, comes from Jessica. I heard that the Department of Labor broadened the definition of healthcare professionals to include home care, non-skilled agencies in the exclusion for paid sick leave and FMLA. Is this accurate? And I think she also has a clarifying question as well.
The answer is yes. We had just issued an alert to our clients yesterday about that, and that indeed is correct, at least as I can confirm because we put it in the alert. If it's in the alert, it must be so. So yes, she is correct.
Great. And then her follow-up question that we're answering live right now. So just to clarify, home care agencies are exempt from paying paid sick leave and FMLA, correct? And do we have to apply for an exemption or document or anything? Do we need to inform staff that we're excluded from paying paid sick leave and FMLA?
So that is my understanding, although this is not my area of expertise, and so I would suggest, particularly on the details, that you talk to counsel and drill down on that. Particularly, the law on that has been moving very rapidly, and you also have to think about what may be going on in your particular states, because there have been changes in state law as well, and I'm not sure which states would be applicable to you.
Absolutely. Great. Thank you so much, Colin. Thank you so much, Jessica. So this next question comes from Tim. So last week I asked about, thank you for joining us again, Tim. Last week I asked about abandonment, and the attorney answered from the angle of whether we should terminate the caregiver or not. That was not the spin I was asking about. I was asking from the perspective of Adult Protective Services here in Washington. So I'd love an answer this week from the perspective of protecting the caregiver and agency from being reported to APS and or sued for abandonment.
Mm-hmm. Now, I know I'm not specifically familiar with how things are run in Washington State. What I can say is, if you are in a situation where you find yourself unable to provide adequate care or keep caregivers safe, then to me, that strikes me as a situation where you should not be providing care. But the important thing in that regard, to avoid those claims of abandonment that you cite, would be to document exactly what the rationale is for your decision, to make sure that it's clear contemporaneously in the record why you decided what you decided. I think in the current context, it's certainly possible that you could still face something from the state level in terms of an enforcement action, but I would expect that the states are going to follow what has happened at the federal level. And if you've seen what at the federal level, in the last 3 or 4 days, everything that applies to the care of individuals who have or may have COVID-19 has been relaxed. The whole idea is care for these people, do what you have to do, and we'll come back later and sort things out, as long as you're acting in good faith. So I think it's important then to document. I think the states will carry through with a similar kind of rationale. Therefore, I think it's important to document your good faith. How can you show that? Make sure that you've got the symptoms documented. Make sure you've got the circumstances documented. What is it about this particular circumstance? Show that you've looked at all the other possible alternatives. Is there some other way to deliver care? We tried telemedicine. That doesn't work. You've tried everything. If you go through that and have that documented, to me, that's going to put you in as good a place as you can be.
Okay. So it actually, these two questions sort of dovetail, and Chad just asked the question. So Chad, we'll unmute you to just get clarity on this from your end. But it also lends itself to, I think, a question that a lot of people are asking, Colin. So seeking clarification, this comes from Geneva. on when a home caregiver with possible exposure can return to work. For example, a caregiver who lives as the first responder who has had exposure to COVID positive patients while taking appropriate precautions. Caregiver has had no symptoms. When are folks cleared to work? I think that's an ongoing concern. And Chad, we're going to go ahead and see if you are able to see if this kind of also is your question as well. Let's see if we can. Can we do that for Chad, Jen, at all? Let's see. In the meanwhile, Colin, do you want to start answering that question, or Maduri also take a stab at it as well?
Colin, do you want me to take the first step?
Yeah, go ahead, Maduri.
So if somebody has had exposure to someone else with known or suspected COVID-19 without wearing a mask, then they should self-quarantine for 14 days. So let me just say that again. So if I am exposed to you, Helen, and you have known or suspected COVID, and I wasn't wearing a mask when I was exposed, close contact, then I need to self-quarantine for 14 days. And the way that the CDC defines exposure is if I was within 6 feet of you for an extended period of time. And I think extended period is probably about 20 minutes or so.
Chad, does that answer your question? I think you're unmuted now.
Somewhat. I just had a client that called, and she had called earlier this week and wasn't feeling well, and now is feeling better. And so I'm trying to decipher, she hasn't called her doctor or gone in because she's feeling better. And I'm trying to decipher when we should have the caregiver go back in to care for her husband and her.
So who has the cough, the client or the caregiver?
The client's wife had the cough.
So if the client's wife has a cough, as you kind of alluded to, she needs to have called her provider. But one thing you could consider is having your caregiver wear a mask when other way around, have the client's wife be in another room and wear a mask when the caregiver comes.
So at what point though is she, I guess it's been unclear as to what point someone's no longer contagious and able to spread whatever they might have after, they're feeling better and have a lingering cough, whether it be from inflammation or whatever. At what point is that we share with the caregiver, hey, if you're going back into the home, we can tell them, yeah, wear the mask. But at what point, if the cough lingers for a week or two, like it does with many respiratory, viruses and stuff, when are they not contagious to someone else anymore?
So that contagiousness issue is absolutely an unknown. That is difficult to tell, but probably if it's just a dry cough with no fever or anything else, and she's had it for a while, it doesn't sound like typical symptoms of COVID. So again, I think that if she is in another room, because then she's going to be 6 feet away anyway when the caregiver goes, I think that that's a good precaution to take.
Okay, and roughly, do we have any generalized recommendation for how long something like that should last? Is it just till the cough is gone, or?
It's really until 14 days after initial exposure. So it doesn't sound like she knows if she was exposed to anybody with it.
Yeah, she's been on self-quarantine at home for 3 weeks. So, I don't know that she even understands why she has anything. She had diarrhea with it, which was, I thought, an interesting symptom. So she's obviously concerned that she, got something, but now that she's feeling better, and it was 3 or 4 days that it lasted, and now she's only got, a dry cough. It just didn't quite all go together, but she felt she had some night sweats for a couple of nights, and but never took her temperature. So it's kind of a mixture of a couple of things.
Yeah, and in a lot of places, she probably wouldn't even meet the criteria for testing herself. because she doesn't have a fever or many of those other things. So yeah, honestly, without knowing anything else, I think if she isolates herself when the caregiver comes, I'm not sure what else there can be to do about that.
Okay.
I mean, I guess the one other thing I would say is, to watch the surfaces in the dwelling unit, is, to understand where she's been and if those surfaces have been disinfected, because I think that to me would be a concern as well.
Yeah, thank you, Colin. We had her, we suggested to her today that now that she's feeling better to just go through and sanitize and wipe everything down. And then we were just the caregiver's not due to be back in there until next week anyways. So we're going to touch base on Monday and see how things are going. But I appreciate the feedback. Thank you.
Yeah, and honestly, anybody right now who has like a cough should be wearing a mask when they're around other people.
Colin, Chad, thank you so much. I really appreciate your question, and you were the first experiment in terms of us asking live questions, so I'm glad that worked out really well. Thank you so much, Chad. Awesome. So we're just going to keep going down the line of some of the questions that have come up. In terms of, it looks like the Department of Labor clarification for healthcare, so now talking about the industry, in order to exempt employer from sick leave due to COVID-19 can be interpreted to include services that looks like North Carolina home care agencies provide. Are certified nurse aides and non-certified nurse aides assist with bathing, dressing, meal prep, toileting, and reminders. North Carolina licenses home health differently, but home care is, in our opinion, still a part of the healthcare community. What are your thoughts? Would love to get your thoughts on that, Colin.
That's tough because I don't practice law in North Carolina, but it does seem like a logical argument to me that those folks are providing, under the prevailing standards, healthcare services.
How would they petition if that is a belief? Who should they reach out to in order to see, what? Yeah. Mm-hmm.
Yeah, you could petition to lots of different people, but the question is, if they're in public health right now, you're not going to get them. And so this is another thing, treat these sort of decisions in the same way you would in terms of making a patient record. Say, all right, again, we're going to try to demonstrate good faith. So what do we do to make this decision? We looked at the standard, we talked to people, maybe we talked to counsel, we document the things we did, we came to this conclusion, that's why we went in this particular direction. So that way, at least if you're second guessed, you have a trail to show what you thought. If ultimately it turns out you're wrong, that the regulators say, no, that's not what we would have done, and they want some money back, hopefully you're only in a position where you're only paying back what they say you shouldn't have gotten paid, or if you didn't pay something, what you didn't pay, and not any kind of penalties or damages.
Awesome. Okay. Thank you so much for answering that. And this next question comes from Patricia. Can we use caregivers who test positive to care for other clients who test positive for COVID, especially those without family? Or should we send them to the hospital or facility for respite care so RNs can check in on them? We're in a non-licensure state and do not have RNs on staff.
Maduri, do you want that one or you want me to take it?
Sure. So again, the CDC has guidelines of what to do in crisis situations. And one of the things, again, I'll share that link with you at the end. And again, one of the things that they state is if there are no personnel available or very limited personnel, that one might consider pairing a COVID positive caregiver with a COVID positive client. One of the problems with that is that we're not 100% sure if once you've had COVID that you have immunity. So what are your thoughts, Colin?
Yeah, I think I come down on that as you do, that we're facing a lot of situations where you have to say, well, okay, it's a last resort. It's this or nothing. And I feel a little bit better about that sort of situation. But if you can avoid these, then you should try to, I think, because there is still so much that we don't know. that we want to try to err on the side of safety when that's possible, but I recognize that it may not always be.
Great. Awesome. Well, I hope that answers your question. So a follow-up question. We're going, a lot of the questions I think that we've had over the last couple of weeks have been about the availability of PPE and then what to utilize in place of what. So I'm going to ask Liz's question because I think it dovetails pretty nicely with other questions around masks and guidance around masks. And then Liz, I will also have you, get a response to this live as well, but I'll tee it up. When we talk about wearing a mask, what type should we be using? Since masks are difficult to obtain, is any type of mask, face covering, homemade, cotton mask? And we had a question earlier about muslin masks as well. In your assessment, what is sufficient at this point, knowing that some of the guidelines are also are shifting and changing? Maduri, do you want to take a stab at this? And then Liz, I'm going to unmute you.
Sure. So CDC, again, I'll provide a link, provides guidance on what to do if there are plenty of masks, if there's limited supply of masks, or if there's an extremely limited supply of masks. So first I'll start off by saying if we had plenty of masks available, we would probably be wearing N95s and gowns for all patients with COVID or suspected COVID. So that is a situation where there are plenty of face masks around, there's N95 respirators around. But as of right now, even if there's plenty of N95s around, direct care workers and anybody shouldn't have to wear the N95s unless they're assisting with procedures such as nebulizer treatments or CPAP. So even if you have plenty of masks, direct care workers should not have to wear N95s unless helping with aerosolizing procedures such as nebulizers or CPAP. That's the first situation. Second situation, if there are no N95 masks and limited surgical masks around, CDC says if you don't have access to N95s, extend the use of the surgical or medical face masks. And that is a very non-specific word of extend. It doesn't give guidance as to how long you can extend it. You could call your public health department. Again, Colin says you might not get them. But I think if you kind of come up with guidelines for your own agency and show that it's well thought out, and if you've done the best you can, it can be reasonable. If you're reusing masks, you still have to be, the worker still has to be very careful with them. Need to be taken off, not touch the front, fold carefully, and kept in a paper bag or another breathable container. The other thing you can do is prioritize face masks for selected activities, such as during care activities where splashes are more likely, like bathing, for example, or during activities where prolonged face-to-face close contact is going to happen. And reserve use of, the other thing is to reserve use of face masks for direct care workers who are at high risk, for example. And at this time, the caregiver should always be 6 feet away from the client except when absolutely necessary, which I understand is often the case. And the any care recipients with respiratory symptoms should be wearing a mask during care when possible. So the third situation finally is if there's no N95s around and no surgical masks available. So the CDC says for these people, you might consider, we talked about this before, assigning workers who have recovered from COVID-19 to provide care for care recipients with COVID-19, but it's unsure if they're immune. And if there are no other options, direct care workers may use homemade masks, such as a bandana or scarf for care of care recipients with the COVID-19, but homemade masks are not considered PPE, and it's not known if they can protect against the virus, but that is a last case resort that some people are resorting to. And I'll say one other thing actually about masks is that in the news, they've been talking quite a lot about whether we should have the whole population wear masks. And again, I think that's a situation that's tricky because right now there's not enough masks even for healthcare workers. And when they talk about wearing masks for the general population, that's still along the same lines as the mask isn't going to protect you. It's still going, it's just protecting the spread of the disease to other people.
Right. And people are asking questions around types of masks, coffee filter masks, muslin masks. What are your thoughts around any type of materials used to protect?
So I think all of these homemade masks with filters or not filters or muslin or these neck coverings, I saw another question. These all fall under the category of if you have no other options, which may be the case. And yeah, I mean, again, there's no science to back any of this up, but certainly there are HEPA filters around. Yeah, and I've heard about vacuum filters, coffee filters, and masks can be made with those, and maybe that's the best you can do. But again, all of those masks really fall under the category of if you absolutely have nothing else. One of the homemade masks isn't necessarily better than any other homemade mask, but I would think one with a filter is probably better.
Thank you so much for answering that. So the next question comes from Rianne. Rianne, I hope I'm saying your name correctly. I'm hearing lots of discussion that home care providers are stating if a client is diagnosed with COVID-19 that they will not provide care. I feel like there are legal implications both ways, as well as not providing care if they have no local family care for them. Is there some legal guidance that can be provided in relation to best practices? I know this feels like a recurrent question, and in the past, I know, Colin, I mean, just recently, you know, documentation is everything, but can you answer Rianne's question?
We can try. I mean, I think there's no broad rule on this that says that every time you must or you should not. I mean, obviously, these are folks who need care, so we want to try to find a way to provide care. And in that context, as Maduri was saying, if you're going into that with the individual having able to wear a mask, you're masked up, you've got the other PPE on, I think you might be able to work in that context, but you've got to have the person providing the care has got to be comfortable with that setting, has got to understand how to use the PPE. And if you don't have anybody available and willing to do it, I think the concern I would have is you don't want to force someone to provide care in that particular setting if they feel as if they are not being provided with what they need to feel safe. That's when I think you'll start to get into trouble. Now, that said, if you properly train people and get them the right equipment, then this can be dealt with in a safe manner. But those are necessary prerequisites.
And as a follow-up to that, this is a very interesting follow-up question from Sherry. How are other agencies streamlining family trying to come visit elderly family after they've been self-isolating? I'll actually posit this question not only to our panel, but this is actually a time for the roundtable to be fully round. If you have any thoughts or if you want to raise your hand, we can definitely get maybe a couple comments on that. And feel free to also chat this among all attendees. How are you managing and streamlining family trying to come visit elderly family after they've been self-isolating? I'd love to hear any of the feedback from our attendees as well. And it looks like we've probably got someone is raising their hand. Sherry, do you want to, let's see, chat? Okay.
Hi.
Hi.
Thank you for taking my question. I do have a partial solution that we're using with our care team members. We are actually using WhatsApp. We're discouraging them from coming to visit, but some of those we just can't force, even though we feel like we should, because we've done such a great job at maintaining the house isolation. But we're using WhatsApp. We're getting people online and using the caregivers' phones if the client doesn't have one to have that personal visit. And they're seeing them. It's taken away some of the anxiety. And that has been 90% successful. We've also encouraged them to make signs and paste them to the outside of the window. We have some pictures we posted on Facebook. It's got a great review and great ideas. And we just have to go back to the old-fashioned way. It's giving the caregivers time to spend some social, creative, recreational therapy and making notes and like pen pals and mailing them, and they're looking forward to those mailers. So we've only had one client out of all of them that's insisting on coming. He feels he's already had it. He gowns up, gloves up, does the overkill, and wants to come and take him for a ride and go through a drive-through. And we can't force him. He's a DPOH. We can't override that. We do let them know how concerned we are about that, but he just does that once every 2 weeks, and then, you know, puts us at risk. So that's kind of how we're doing it. I was just curious on how everybody else was doing their thing and offering some information about what we're doing.
That's great. It looks like people are already chatting back about how they're doing that. So Pamela is saying, oh, I'm so sorry about that. Let's see. So Shell recommended FaceTime. So it looks like some of you all are digitizing this opportunity to visit and check in. Google Duo for those that don't have FaceTime. So that's from Allie. Thank you so much for offering back responses. And Sherry, that sounds like a wonderful way to facilitate. It's almost like it's a very analog way of doing it, but that's wonderful that you all are facilitating that as well. So Robin, thank you so much, is saying that they use Zoom, FaceTime, WhatsApp, whatever the client has access to. So a number of different ways to facilitate that across the board. Thank you, Sherry, for your suggestions. Great.
Thank you.
Mm-hmm. Awesome. All right. So our next question, and I think this is really interesting, as we're seeing telephony become more of a way of sort of facilitating care. Can we do telephonic visits for our case monitoring notes? Colin, Maduri, what are your thoughts on that? And this comes from Jill.
I would think so. Given the overall relaxation that we've seen in telehealth, related HIPAA issues, I don't see why not. Maduri?
No, I don't. My question would be, Colin, would they be able, how would that work when it's non-medical? Like if it's, so they wouldn't be billable, they would just be okay to document. Is that correct? Right. Yeah, okay.
Mm-hmm. Great. And so this is someone calling, well, who has a question from it as an independent living community. So we provide services at an independent living community regularly, as well as in the past have been very active marketing and hosting events there. They had a suspected COVID-19 case and went on lockdown, but when the testing came back negative, reopened all of their doors and are pushing for things such as happy hour and card games. How do you recommend we communicate with places like this with the goal of getting them to take it seriously? Their population inside the community, while independent, are still some of the most vulnerable to this pandemic. Would love some of the panelists to chime in. And if you also have suggestions, if you're in the same boat as a home care provider, please also message out to the community as well.
I mean, that is not what the CDC recommends. So that's clearly going against what national advice is. And this disease is highly contagious, and it doesn't take much for it to get into a facility like that. As we've seen in Seattle, we've seen in multiple nursing homes now, all it takes is one person and it'll just spread. So yeah, I don't know what else to say about that other than it's just going against all recommendations.
Yeah. Yeah. I think at this point, I'm very surprised, just given sort of the public outcry and that, that has been the case. If you have any sort of clarifying comments, if the person who posed the question, Joseph, you're on the line, would love to get any sort of clarifying thoughts on that. Just because, it goes not only against sort of what we know is our CDC guidelines, but also just what's happening sort of in the public in the general public. So I'm really curious if folks on the line or attendees have any suggestions for how Joseph can best handle that, that'd be great.
I mean, I would just, Helen, if I
Okay.
could just add, I would recommend to you, there was a very good article in the Wall Street Journal about how the issues in the Seattle area nursing home came about. And it's a very graphic description of something as simple as they had a Mardi Gras party. They debated whether to have it, they had the party, and then people started dying. So show that to them, and that maybe that will bring them to their senses.
Yeah, I mean, very similar for these sort of, they're called super spreading events, I believe.
Right.
You know, this would be really unfortunate for this site to be, you know, especially given what we know now, that'd be really unfortunate for that to happen there. So I'll move on and we'll come back to that as we're getting any new responses. So this question comes from Terry. I cannot seem to get a direct answer as to having a caregiver get tested if we think they have been exposed. It's like we have to wait until they have symptoms, which is too late. Is that generally what you're seeing? Colin Maduri, would love to get your thoughts on that.
So yeah, let me just pipe in for a second, Colin, is that, again, this is a shortage of resources issue. And if we had plenty of tests available, certainly everybody could get tested. But this is triaging the number of tests that we do have, and it is improving. There are more and more tests available, but right now there's strict guidelines as to who can get tested, and it's primarily hospital staff, those that have had a direct close contact, or people that have symptoms like fever and something else. So yes, absolutely. There's just not enough testing, and I think that that's all there is to it.
Yeah, I'd add, I mean, even as more testing comes online, we're seeing that there are substantial delays in getting the results back. The labs are backed up now, so it's working. The delays are working their way through the system. That'll eventually resolve itself. More capacity is coming online every day. The throughput is coming faster. But we're still several weeks away from having the sort of turnaround on tests that we would like to have.
And then just in terms of spreading and quarantine, I'll just, just quickly kind of go through some of the questions that we've had come up as follow-up to questions that we've asked. We have an HR employee that was in contact yesterday with an employee who just found out this morning that her mom may have COVID-19. The HR employee is on a 14-day quarantine as of this morning. Should all office staff go on a quarantine at this point?
No, that's not what the recommendations are. If you've been exposed to somebody who's been exposed to somebody, that's not in the guidelines that you need to quarantine yourself. So the HR person, if she had recent extended close contact with her mother, then she needs to go on quarantine, but not everybody she's been exposed to, unless she's having symptoms, in which case, yeah, that's another story. But if she's asymptomatic, no.
Thanks so much. So what are some other, and I think this is a really kind of good wrap up as we are, looking at some of the rest of the questions here. What are some things that we can do, this comes from Robin, to make sure clients and caregivers are using the proper safety procedures to keep the spread of COVID minimal? I will say, to preface before our panelists have a chance to respond, we do have a COVID class that is made widely available. So whether you're a customer or not of CareAcademy, we offer that as a way to get that to your direct care workers, your caregivers, in order to learn some of the best procedures at this point to protect themselves. But would love to know if you all have any other suggestions for Robin and for the folks who are attending today.
The question is, how can we ensure that the workers wear the proper, what they're supposed to?
What are some things we can do to make sure clients and caregivers are using proper safety procedures? At this point, actually, maybe the better question is, what are the recommended or proper safety procedures?
So again, I would encourage people to look at the link that I'll have at the end about CDC recommendations, but generally speaking, anybody that has respiratory symptoms and or a fever should be wearing a mask, and that includes the client and the caregiver. Anybody who's had close contact for an extended period of time with someone with suspected or known COVID needs to self-quarantine. Anybody who lives in a house with other people and has symptoms, respiratory symptoms, or is waiting for a test should self-isolate in that home. And caregivers should try to stay 6 feet away at all times. And if the client has symptoms, the client needs to be wearing a mask at all times. Caregiver has symptoms and no COVID, they should be wearing a mask at all times.
Great. Several of you chimed in. Where do we find those classes? So our classes can be found, if you're a CareAcademy customer, that's, you can have that directly put onto your dashboard as part of your classes for your direct care workers. If you're not a CareAcademy customer, that is made live for your caregivers. If you go onto the website, and we'll also make sure we email this out and offer this actually in the end of our webinar today. Caregivers, there's a short bit.ly link. It's a web-based class where they can get a certificate of participation at the very end after taking a short quiz on the materials that they've learned. So that can be found directly at www.careacademy.com, and we'll definitely send out links. Yes, Katya, we'll definitely do that. So just in terms of, as we're wrapping up today, just know, everyone on the call, that this is an ongoing weekly process. We'll keep having these roundtables as long as you're still coming. As long as we're all sort of sheltered in place, we'll still have these weekly webinars to answer your questions, because we know so much is changing about what we know about this disease and how it impacts our businesses and the caregivers that serve with us, as well as the clients and the patients that we serve as well. So with that being said, I wanted to thank Maduri and Colin. Thank you so much for answering our questions today. Keep submitting questions. We'll try to get to as many of those as we can every single week. And if we can go on to the next slide, Maduri, would love some of your takeaways, given some of the questions that were asked today. What are your takeaways and your thoughts? Oh, you're muted.
Just 4 things with some links people are interested. So one is the CDC recommendations for PPE, which are different in crisis situation. And so the CDC specifies it's for home healthcare personnel, which I think it's probably fair to include non-medical home care in that as well. That's the link. Secondly, consider allocation of staffing, as we talked about before, if there are limited staff, and there's a link for that, CDC site for crisis alternate strategies. Thirdly, you need to take precautions in the home, environmental cleaning, et cetera, and for home health workers. So I have 2 links there. One is for environmental cleaning, and the other one is precautions the worker should take. And finally, CDC recommendations for return to work policy and restrictions for healthcare workers. And there's a link to that.
Great, thank you. And then Colin, what are your takeaways?
And some of these build on the things I was talking about earlier. Think about what you can do remotely where you don't have to be there. Obviously, that's the best way to protect both sides of the relationship. If you're not there with the individual, what can you do that's remote? What are your capacities now? What can you build? Because this isn't going away. Think about what you can do now in terms of telehealth. There's a lot of opportunities there as well. And it's really going to be a tool now, from now onward, you have to deal with. Secondly, and I've said a number of times, don't let your documentation slide. It's easy to do. You're busy. Oh, I don't have time for it. I think even though the standards for a lot of things are being relaxed, that doesn't mean they go away. And if there's a problem, you want to have documentation that shows you were acting, at the very least, that you were acting in good faith. So you've got to keep that in mind that you have, because if you have no records, how are you supposed to show somebody that you were acting in good faith? You've got to have records. You've got to document the decisions you're making. It's just as important now as it ever has been. And then, and to quote Fleetwood Mac, don't stop thinking about tomorrow. I know we're just into April and it's going slow and it's hard to tell one day from the next, but I think now for the next week or so, we're going to get a little bit of the extreme pressure let off. And so take the opportunity, say, all right, let's look when we don't have to look at tomorrow. What's next week look like? What's the rest of the month look like? What's May and June and July going to look like? What are we going to do here? Start thinking about that, because as Max said, it'll soon be here.
Absolutely, absolutely. Thank you so much for your takeaways. So additional resources. A lot of you all asked, where's the certification? So if you go to bit.ly/COVID -19 certification, you'll find the free certification there. Also, we have a blog, the free class, and of course, our roundtables and our weekly updates as our resources that we're always refreshing here at CareAcademy, specifically for your use and your staff's use. So keep coming back. And also, this is your chance to recommend what are some the other ways that we can support you and your staff in this time, because we're all in this together. And so the next slide. Maybe this is a good time. So the COVID training, that's the link on it. Again, if you are a customer of CareAcademy, it's made available for as many seats. We're waiving those seat fees up until April 24th, and really making sure that's available to your direct care workers. It's a good time to tell you all, next week we have new panelists. So Tim Bergers, the Associate Director for the Home Care Alliance in Massachusetts, will be on, and Sheila Davis, the Executive SVP of Operations from Always Best Care, will be our guest next week and offering their insights, as well as, of course, Dr. Reddy, as long as she's available, to provide our weekly healthcare update as well. So with that said, I want to thank everyone. I hope to see you all next week in good health. Let us know how we can support you. Email and respond back to the newsletters and to the updates that we're sending out. Let's get through this together. Thank you so much, everyone.
Thanks for your questions, everybody.
Bye. Thank you, everyone.